I have no conflicts. I want to acknowledge my co-authors and my co-chair, Tom Ryan. The document hasn't been published yet, and I want to emphasize that we turned it in on time in January, and it will be published in the middle of July in JAC and in JACE in August. I don't know why it's been delayed. But the ATS, the Advanced Training Statement, is a competency-based education. Competency means having the necessary ability, knowledge, and skill to do something successfully. It's replaced knowledge objectives. It's more focused on outcomes of education and demonstrations of ability. It's been adopted by the LCME for undergraduate medical education and the ACGME for graduate medical education. The ACC established competencies for adult cardiovascular fellowship in 1995 with the first COCATS document. And why they called it COCATS, because it doesn't really stand for anything, I don't know, but that's what we use. There are 3 levels of training recognized in graduate medical education. One is level 1, basic exposure to a field required of all trainees to be competent cardiologists. So, for example, I'm level 1 in angiography. I look at all my patients' angiograms, but I'm not competent to do an angiogram. Level 2 is additional training necessary to develop competency in specialized areas that enable a cardiologist to perform or interpret specific studies. And level 3 is advanced training in specialized areas that enables a cardiologist to perform, interpret, or train others in advanced activities. COCATS 4 was published in 2015, and it really only focused on level 2 training. It noted that level 3 training in any field would require additional years of training, except ECHO was given a pass. You can do level 3 training in 3 years, but it takes a very focused fellow to do that. Why did we need an advanced training statement? Well, first of all, there are advanced training statements in clinical EP, in heart failure, and the ABIM now recognizes a number of advanced training pathways, interventional, heart failure, congenital, but the ECHO exam is not an ABIM exam, and so there really is no ABIM advanced training pathway, and that's why we needed this document. The NBE began offering certification in ECHO starting in 2001, and the current requirements for sitting for the exam require only that you're level 2 trained and not level 3. I want to emphasize that the reality is the NBE used to say if you were level 3 or not back 20 years ago. It doesn't anymore. And the only person who can certify somebody as level 3 is the echocardiography program director in conjunction with the general fellowship director. Passing and taking the NBE exam is required but not sufficient, and this is the primary reason for the existence of this statement. So here is the list of authors. As I said, Tom Ryan, another past president of ASE, was my co-chair. And there were a number of representatives from all the various cardiology societies, but also from critical care, cardiac anesthesia, and a number of other organizations. Also, Deb Agler was one of our authors, but took a job with industry in the middle of the writing, and so she couldn't be listed as an author, but she was a great contributor. So the required faculty, first of all, in the document, training has to occur at an institution with an accredited cardiovascular training program. The ECHO training occurs in a lab directed by a level 3 trained NBE certified echocardiographer. The program director, who isn't necessarily the lab director, also has to be level 3 NBE trained. It's recommended that all of the faculty be NBE certified and that the majority be level 3 trained, and faculty should be engaged in a research or scholarship broadly defined as teaching or research. I want to emphasize that experienced sonographers are essential for a level 3 training lab. We need sonographers who are expert in the field and committed to training fellows. Obviously, sonographers must be given time and recognition for their efforts in training the fellows. They cannot do 15 studies a day and be expected to make the fellows know what the heck they were looking at or how to hold the probe. And level 3 training directors need to own this and make sure that sonographers have access to educational opportunities and get credit for their teaching. A broad range of pathologies is required. The writing committee considered it unlikely that institutions with less than 7,500 cases a year would have a robust enough clinical exposure. Also, the lab needs to be IAC certified, and that is an absolute requirement. If outside rotations at other sites are needed, IAC accreditation is not required, but the program director must certify the quality of that outside rotation. There are 6 competency domains. Those of you who are educators should recognize these. They're in, as I said, LCME and ACGME language. And so this is what it looks like. You can see here we have medical knowledge, we have physics, hemodynamics, and then general competencies for all conditions: know the echocardiographic findings, know the limitations, know the importance of serial comparisons and the problems with those. And this means that this is required to be level 3. This is all. The specific areas for medical knowledge are what you would imagine. They cover the broad range of cardiopathologies, including adult congenital heart disease, and critical care and perioperative. But I want to point out that under patient care and procedural skills, some things are required by every level 3 trainee, and some are additional exposure. So the skill to acquire and interpret images during structural heart disease is not required of a level 3 trainee, but we specify what is required if you want to say you're level 3 in interventional echo. So here are the numbers. People ask me, where did the numbers come from? Guess where? Consensus. There's no evidence-based, there's no documentation, there's no studies that say how many we should do. We did not, unlike other documents, increase the number of scans that the fellows needed to do. There's a lot of other things level 3 trained fellows need to do. Scanning is not one of them. But they need to be excellent scanners. So some fellows may need some additional training, but some may not. There's an increase, 450 additional studies in transthoracic, transesophageal, an additional 100. The 3D is required and should be done during these studies. It's not additional. Contrast is 100. And again, during these studies, strain and stress. The ACC doesn't like us to show the numbers without the footnotes. These are numbers considered necessary for the minimal numbers considered necessary for training and competence. Some people may require a ton more. Some people may require an infinity number more. But exposure to a broad range of pathologies is expected. And so one comment I've had is, wow, that's a lot of contrast. It's only 13% of your total TE requirement, and that is a low estimate for what your lab should be doing for contrast. And certainly stress echoes, the estimate is even higher, maybe 50%. The required procedures are what I just said, and TEE must be complete studies on patients with a broad range of pathologies. Stress echoes, there have to be a sufficient number of normal studies. Contrast has to be used. 3D echo has to include image rendering, manipulation, and so does strain. Now this table 3 are the additional procedures that are necessary. for competency in interventional ventricular assist devices, intraoperative, and intracardiac. These are not required to be level 3, but if you want to say, I am a level 3 interventional echocardiographer, you have to meet these numbers. So, General Cardiology Fellowship, we recognize that this will limit some labs that currently turn out level 3 training, trained fellows will not be able to. And the completion of all of this in 3 years requires really a very early commitment on the part of the fellow that they're going to become level 3 trained. One of the things that we note is that there is a way for attendings after, in their early or first year of attending, to be a hybrid, attending in the CCU but a fellow in the echo lab and complete their training. So this isn't intended to be a strict rule, but to really help people reach level 3 training and to be flexible. Just some frequently asked questions. Can 2 fellows interpret the same thoracic study? Sure. Can 2 fellows do the same TEE? I don't think so. Can any TEE count toward the procedural volume? No. If you drop the probe, look at the left atrial appendage, and get out of Dodge, that's not a full study. And can a stress echo be counted twice? No. Research and scholarship are important. Original research and mentorship by academic faculty is preferable, but certainly QI projects, educational projects, journal club, and scholarly presentations are expected. There were 600 public comments on this document, which is a record for an advanced training statement. I went through all of them, and the research and scholarship requirement got the most comments. Some people said, that's ridiculous. Everybody should do 2 years of full-time echo research to be level 3. And some people said, level 3 should not require any scholarship. It was about 50-50, and so our requirement stands. So what does this have to do with quality? Competency-based training requirements emphasize expertise rather than pure numbers. It allows for individual variation in career plans and institutional variation in programs. It emphasizes the need to maintain lifelong learning goals, and it assures that echocardiographers are well-trained and hold up their end of the high-value cardiac imaging proposition. Thank you for your attention. And not that I'm competitive, but I'm under time.